Hopefully this is turned on. Thank you very much for the invitation to speak, Umesh, and it's been great to meet all of the members of the program. I think initially I was assigned the topic of talking about animal models of thrombosis, and we've already heard some examples in previous talks of some really elegant studies. So I think I'm going to take advantage of the fact that I'm speaking last and modify what I'm going to say to talk to you a little bit about how we've used certain murine thrombosis models to identify a particular protease in the coagulation cascade, factor 11A, as a target for thrombosis, and how we're using those models now to assess some of the novel compounds that are being generated in the program. So I'm a hematologist by trade, so I'd like to start these discussions with some basic terms just so we're all on the same page. But we're going to be talking primarily about the mechanisms for blood coagulation, which, as you, I think, are aware, involves the interaction of platelets and components of the plasma portion of the blood with damaged blood vessels. And the general idea behind the concept of hemostasis, normal blood coagulation, is that triggers for both platelet activation and fibrin formation are sequestered from the normal bloodstream by the healthy endothelial layer, and when that's interrupted, you get exposure of these to elements underneath the blood vessel endothelium. The red staining material here is tissue factor, which you heard about in the previous talk, and that's going to result in a clot formation. So to a hematologist, the concept of hemostasis implies clot formation where a blood vessel is injured, but just as importantly, maintenance of blood in its fluid state where the blood vessel isn't injured. And given that definition, thrombosis and bleeding are often described as being on a continuum with hemostasis, with thrombosis essentially being hemostasis in the wrong place and bleeding being the lack of hemostasis where it's needed. And what I hope to convince you of today is that there may be prospects for identifying things that will contribute to thrombosis that don't play perhaps as important a role in hemostasis as some of the enzymes you've heard of today, like thrombin and factor 10A, and therefore that we might be able to develop treatments for thrombotic disease or preventive measures to prevent thrombotic disease that don't compromise the normal hemostatic system. Now, you've seen a lot of different models of blood coagulation in the talks previously, and I'd like to go over the one that we use in our laboratory. So central to the role of the hemostatic process is generation of the enzyme thrombin, as you've heard. And thrombin comes from a precursor in plasma called prothrombin. And actually the generation of alpha thrombin, which is the major activator of PARs, protease activator receptors, the protease that cleaves fibrinogen and fibrin, proceeds actually through some intermediates which also have some activity. So my laboratory concentrates on factor 11, for instance. These intermediates, mesothrombin and mesothrombin desF1, in addition to alpha thrombin, can activate factor 11, so it can start the ball rolling even before you have full alpha thrombin generation. This, this is a trypsin-like protease. It has two exocytes that are involved in interacting with a lot of other macromolecules, substrates. The exocyte 2 is where heparin binds. The other coagulation proteases that I'm going to talk about today also tend to have a heparin binding site or residues that can bind heparin-like molecules in a similar position to where you find them on thrombin. So the mechanism, the model we like to use is as follows. The initiation of hemostasis involves factor 7A, which is a protease in plasma, coming into contact with its cofactor, tissue factor, at a site of vascular injury. So this is the traditional extrinsic pathway of coagulation, the basis of the prothrombin time assay in clinical laboratories. And it's going to start the process of thrombin generation by activating factor 10A in a calcium-dependent manner, and 10A with its cofactor is going to make some thrombin. 7A tissue factor is also a potent activator of factor 9. Okay, in fact, factor 9 and factor 10 are homologs, and factor 9A along with its cofactor, factor 8, is going to sustain the process of thrombin generation by activating additional factor 10. So the importance of this particular reaction to hemostasis can be seen in people or animals that have the disease hemophilia. They're missing factor 9 or factor 8. And the type of bleeding disorder that somebody who has hemophilia is troubled with I think can be nicely demonstrated in some mouse models where you either clip off the end of the tail and see how long it takes for bleeding to stop, or you puncture, for instance, the carotid artery and see how long it takes for bleeding to stop. In a wild-type mouse, those two types of injuries will result in profuse bleeding for a minute and a half, 2 minutes, and then it stops. The same thing will happen in an animal missing factor 9 or factor 8. But then about 30 seconds after the bleeding stops, rebleeding occurs, and the animal will exsanguinate, essentially. So without this backup mechanism, even though you can get a clot to begin with, you can't consolidate it, and that causes the hemostatic problems you see in hemophilia. Now, the mechanism you're looking at here is the core of the vertebrate coagulation mechanism. You find this in almost all fish, all the way through to mammals. But mammals have parts of the system that you don't find in other vertebrates. In mammals, you have another protease, factor 11A, which we're going to concentrate on today, which is also an activator of factor 9. And as was mentioned by Dr. Robeson in the discussion, people missing factor 11A can bleed. So we have to account for it somehow in this model. And if you look at where these people tend to bleed from, it's usually from tissues that have high fibrinolytic activity, the oropharynx, the urinary tract. So again, this is probably more of a sustaining mechanism, trying to maintain a clot once it's formed under duress, so to speak. Now, in the traditional coagulation cascade mechanism, factor 11 is activated by a protease called factor 12A. Factor 12A is a part of a system called the contact system. And our best guess at this point is this really isn't required for hemostasis. What it is it is part of a host defense mechanism, probably part of the innate immune system that's responsible for defending against microorganisms. It's a surface recognition system. When we do tests like the PTT clotting assay, which you've heard about, we put charged substances into the plasma, and that triggers an intense activation of factor 12 and triggers clotting through this pathway here. But since we don't have abnormal bleeding in people lacking factor 12A, there has to be some other mechanism for activating factor 11. And we and others have identified a number of years ago that some of the thrombin or mesothrombin or species generated early in coagulation can actually feed back and sustain the coagulation process through factor 11. So, based on the observation that bleeding in factor 11 deficiency is relatively minimal and bleeding in factor 12 deficiency is absent, for a long time the general idea, based on thrombosis is simply hemostasis in the wrong place, that these are probably not major contributors to the thrombotic process. But that attitude changed a bit in the year 2000. Joost Myers and his colleagues in Amsterdam published a paper in the New England Journal describing the correlation between factor 11 plasma levels and risk of venous thrombosis, and showed that those people who were at the high end of the normal range had about a twofold increased risk compared to everybody else within the normal range. And so that got people thinking, well, perhaps this protease is involved in thrombosis. So, just to give you an idea of the different phenotypes that we see with mice that are lacking these different proteins and how they, I'll just briefly, so that you're familiar with how they correlate with humans lacking those. Animals lacking the vertebrate core of coagulation, the 10, the 7, the tissue factor 5, and prothrombin, will die in utero or shortly after birth from excessive bleeding. Essentially, once they develop a working circulatory system, a substantial percentage of them die from bleeding, and the rest will die after birth. Animals lacking factor 9 and factor 8 have hemophilia. In a mouse, that's not as severe a condition as it is in humans, but if they get cut or something like that, they will tend to exsanguinate. And then mice lacking factor 11 or 12 don't have a hemostatic abnormality that we've been able to demonstrate. So the 11 deficient mice are a bit different from humans, at least in that regard. So, to explain why we're interested in targeting factor 11, I think this was, I'll go through this quickly because this was reviewed before. If you look at the current therapies we have for reducing thrombin generation, they are true anticoagulants in the sense that they don't only inhibit thrombus formation, it's pathologic, they inhibit normal coagulation. So agents like the drug warfarin will reduce the vitamin K dependent clotting factors. And drugs like heparin and some of the direct thrombin inhibitors directly attack the cascade at the level of thrombin, we've seen today how thrombin works, so we don't have to go over that. And then there are a host of new factor Xa inhibitors that are coming online, including relatively new rivaroxaban and recently FDA-approved apixaban. And these drugs are approved for treating venous thrombosis, preventing strokes and atrial fibrillation, and being used in high-risk situations like knee replacement surgery and hip replacement surgery. But all of these are going to be associated with some risk of bleeding because they are going to cripple the components of the clotting mechanism that are absolutely essential for hemostasis. And so with the clinical data suggesting perhaps there's a correlation between factor 11 levels and thrombotic risk, the thought that maybe factor 11 would become a reasonable target for anticoagulant came to the fore. And of course, blocking factor 11, at worst, we would suspect, would create a bleeding diathesis that's relatively mild. It would essentially require certain types of trauma to induce it, as opposed to the spontaneous bleeding episodes that sometimes occur in people who are on warfarin and heparin and some of these other drugs. So we use mice have been using mice extensively to try to figure out exactly how factor 11 participates in the thrombotic process, and also more recently in collaboration with Umesh's group to take a look at some drugs that actually target this protein. And for us, mice are relatively inexpensive to raise and maintain, so they're our favorite thrombosis model. It turns out the thrombin generation mechanism is generally similar to that in humans. There are some incompatibilities around the issue of TFPI and tissue factor and factor 7A. And in fact, when you look between mammalian species, that tends to be where a lot of the variability is. But we're looking at the so-called intrinsic pathway, and so that wasn't as much of a concern with us. Their genetics can be easily manipulated, and you can also transiently express proteins in these animals through a technique I'll show you, and transiently knock them down, which means you can change things over time with them. So there are a host of different techniques that have been applied to the factor 11 deficient mice that we've created and factor 12 deficient mice that have been created by Thomas Rene in Sweden. And we're going to go over the results with some of those, but I'm going to concentrate on arterial thrombosis. And as you've heard some of the pros and cons of the different techniques that are used. We like using ferric chloride injury only because 11 deficiencies, you'll see, causes such a dramatic effect. And we've actually been able to titer this to get a relatively reproducible level of injury. But there's a number of different types of injuries that can be used. For venous thrombosis, you can use ferric chloride, but I think that in my mind, the venous thrombosis models are not optimal. When you use venous injury, chemical or electrical, you end up getting a clot that looks very much like an arterial injury in a mouse. Very rich in platelets, relatively depleted in red cells. There's fibrin in it, but a true venous thrombus in a human is actually relatively red cell rich with fewer platelets in it, and it's caused primarily by stasis. So the stasis models are probably best in those regards, but it's difficult to do a good stasis model on a mouse. You can ligate the inferior vena cava for a few minutes and see how big a clot gets, that kind of thing. But it's simpler to, the arterial thrombosis models I think are a lot more straightforward. You can also induce disseminated intravascular coagulation by infusing various compounds into the mice, and we won't have time to talk about that today. So what I want to do is talk about how we've used some of these models to identify targets that are potentially useful for antithrombotic therapy, and then talk briefly about some of the results we've gotten relatively recently with the compounds that Umesh has sent us. And then actually show you how we're starting to study structure-function relationships in factor 11 within the mice to identify functions that really aren't obvious when you look in static systems. So I think that the ferric chloride model was described. The model we've looked at occlusions of carotid arteries and also mesenteric arteries, and I'll show you some data for both. But the general idea here is we have a Doppler flow probe on the carotid artery, which is exposed surgically. A small pad saturated in ferric chloride is applied. depending on the concentration, this causes severe damage to the blood vessel and usually causes endothelial desquamation. Collagen is exposed, and in fact, some people have actually measured soluble collagen increases in the plasma. It's a bad injury done in the typical manner. You get platelet adhesion and eventual complete occlusion of the vessel. From what I understand in the cremaster muscle with the laser, it tends not to be an occlusion. Sometimes occludes. Here, complete occlusion is the general rule.
The diameter we use is smaller than the prepared one. The prepared, when they use it, like 200 micrometer, but it's usually 40 to 65 meters.
Okay. All right. Well, here we usually end up with complete occlusion. The animals actually tolerate this relatively well. They don't have a stroke, and if you leave them sit long enough, they'll eventually recanalize this and heal without any sequelae. But so the ferric chloride diffuses through desquamation, and you see platelets accumulating. They're eventually going to occlude. Now, as it turns out, the usual concentrations of ferric chloride used for the carotid artery models in rodents are fairly high. In rats, they can be 20% or higher. 10% is not uncommon in mice. And it turns out that you can actually titer the effects of the injury by scaling down the ferric chloride concentration. When we started to do this, we thought we were going to end up with an assay that really was difficult to reproduce. That every time we did it, we're going to have to re-standardize it. And that turned out not to be the case. In C57 black 6 mice that are anesthetized with pentobarbital, if you use 3.5% solution of ferric chloride, you'll get reproducible occlusion of the carotid artery in 5 to 10 minutes. And that's really stood the test of time over a number of years. If you change the anesthetic, you change the strain of mouse, you get a different result. So higher concentrations are obviously going to cause greater levels of injury up to a point, and they occlude. But as you back off on it, you get to a point where you don't. And this was actually pioneered by people who are interested in looking at antiplatelet agents in this model. The ferric chloride model is difficult, and the carotid artery is difficult to use on antiplatelet agents. This kind of injury is usually resistant to aspirin therapy, that kind of thing. So with this modified model, let's take a look at two commonly used drugs in cardiology, aspirin and then heparin, which we've been comparing to many things over the course of today. So at 3.5% ferric chloride, which is the low threshold, you actually do start to see some effects of aspirin in this system, and clopidogrel actually has an even greater effect, but I don't have that data here. However, the effect is lost at 5% ferric chloride. So just remember that concentration of ferric chloride. With heparin, this is a concentration, a bolus, that would be comparable to what we might give a human who came with a deep venous thrombosis, a pulmonary embolism, something like that. And this is a somewhat greater than typical therapeutic dose. And you can protect the animals at 3.5% ferric chloride. At 5%, though, even with that relatively high dose, you have a number of animals who are occluding, and you have to go way up to concentrations that are actually dangerous to protect the animal at 5% ferric chloride. Now, in some people's hands, the ferric chloride model is used in a manner where you determine the time to thrombus formation. In our hands, for whatever reason, it's an all or none phenomenon. Either the animal is going to occlude or they're not. So this is actually indicating the times to occlusion. About half the animals are occluded and half are not. Okay. So with that as background, we decided to compare animals that lack factor 9, lack factor 11, and lack factor 12 for their resistance to thrombosis in this graduated ferric chloride model. And the 9 deficient mice came from Darrell Stafford at the University of North Carolina. They have the murine equivalent of hemophilia. These are results from a tail bleeding time rather. And if you clip off the end of a factor 9 deficient mouse's tail, most of them are going to exsanguinate unless you cauterize the tail. Whereas the 11 and 12 deficient mice essentially look like wild type mice. And here's some effects of some of the anticoagulants we've been looking at. So we were somewhat surprised to see that factor 11 and factor 12 deficiency produced a comparable antithrombotic effect in this particular model to factor 9 deficiency without the associated bleeding abnormality. So what you're looking at here is the percent of mice at each of the different ferric chloride concentrations that occlude or have patent arteries after 30 minutes. And you can see once you get up to about 7.5%, the animals are starting to have some occlusions and some are remaining patent. And as you go higher, they all occlude, with the exception of some animals with factor 12 deficiency. Initially, we thought this might be a strain background phenomena and back-crossed mice to try to get rid of whatever effects might be due to different strains. And the abnormality persisted. As we're going to see, mice may be somewhat different than primate strains in that their contact system and contact-induced thrombosis is very, very pronounced. The activation of factor 12 in the system is probably through exposure of the proteins to polyphosphates that are being released from activated platelets, and it seems to dominate the thrombotic process in mice. That may not be the case in primates, and I'll show you that a little later. So you've seen images like this of fluorescent platelets accumulating, and you just don't get those occlusive thrombi in 11 or 12 deficient mice. Now, in collaboration with Thomas Renée at the Karolinska Institute, we also looked at occlusion in a different vascular bed in mesenteric arteries and veins. So here the vascular bundle, which involves an artery and a vein, are isolated, and the vessels are exposed to ferric chloride. And let's see if I can get this working. So in a wild-type mouse, typically what's going to happen, the bigger vessel on top is the vein. This is the artery. The blood's obviously running in opposite directions. You start to see the accumulation primarily in the low-flow vein first. It's a little harder to occlude an artery because of the higher shear. The clots form, they fall apart, but eventually you're going to end up with complete occlusion of the vessel like so. Oops. Now, in a 11 deficient animal, and this is actually compressed time. This is about 20 minutes worth of observation. What's going to eventually happen is you're going to see clots forming along the walls where the injuries have occurred, but there's just breakage and embolization. There's an inability to sustain growth of the clot. And this is actually something we're going to see in a primate model as well in a bit. Now, we tried to take a look at this in a human ex vivo system. So our impression was we're getting platelet binding to surfaces, but we're not getting three-dimensional growth of clots. And in fact, we were able to duplicate that in a human system where we're passing blood through a capillary tube that's just coated with collagen. So this isn't a blood vessel, it's a pseudo blood vessel. And what happens over time is you get platelets accumulating and fibrin forming on top of that. Here's platelet accumulation in green, fibrin formation in red, and the two superimposed. But if you go and block factor 11 with an antibody, or factor 12, the corn trypsin inhibitor, you have a reduction in fibrin deposition to almost complete blockage with the anti-11 antibody and partially with the 12 inhibitor. And that results in a failure of fibrin formation, but it also affects platelet accumulation. So what we're looking at here is confocal images of the same thing we just saw before, and then we're reconstructing the three-dimensional height of the tube. And essentially what we get is complete obstructions of the tube over time. And these are fluorescently labeled platelets. But in the presence of the 11 inhibitor, you just don't get growth of the antibody. And 12 inhibitors will do that to some extent. So this is sort of an indication, and we'll see again in a baboon model later on, that 11 really is important for the three-dimensional growth of the clot. In the mouse, it seems to be largely 12-driven, its activation, and we're not so sure in a human. Okay? And that's illustrated here. So our current working hypothesis is the difference between hemostasis and thrombosis in these models is that in hemostasis, the clot formation, this is going to be fibrin and platelet deposition, is mostly within the wall of the vessel. It should maintain the integrity of the lumen. But in the thrombosis models, where we're damaging the endothelial cells, we're getting intravascular clot, high shear is probably resulting because of the narrowing of the vessel, and for some reason 11 and 12 are important for contributing to the ultimate occlusion, and when they're not present, the high shear fragments the clot and doesn't allow it to go beyond a certain size. We were concerned that what we were looking at was essentially an artifact of the model we used. The comment was made, all of these are essentially models, and they could be, have their own features that aren't going to really be reproduced in vivo. So we looked at carotid artery injury with a laser injury. And this is a relatively simple assay. You infuse a dye, an eosin-related dye called rose Bengal, that doesn't cause the animal any harm. You go and illuminate the artery that you want to form a thrombus in with a laser of a certain wavelength. This is converted to free radicals at that site, and the end result is occlusion. And so a typical tracing with a mouse in this particular model is going to be similar to the carotid artery. This was alluded to before. You kind of get this pulsatile nature where the flow starts to drop, and then it goes back, and eventually you go to the point where you're occluded. And here also, we saw that 11 deficient mice had a consistently longer time to occlusion than wild-type mice, and 12 deficient mice even further prolongation than the wild-type mice, or the 11 deficient mice. So it's not clear to us at all why 12 seems to be a more, the 12 deficiency has a more pronounced effect in these models. It's consistent in mice. We're not sure what's going on. It could be that mouse 12A activates something further down the cascade and bypasses the need for 11. We've looked for that phenomenon in human plasma and haven't been able to identify it. Certainly, actually, it's factor 11A can bypass can actually activate more than factor 9, but alternative targets for factor 12A are a mystery at this point. This is actually data from the laser injury model that was from Dr. Robeson's group, generated a number of years ago by Reagan Baird when he was working with Barbara and Bruce Fury at Harvard. And just to refresh your memory, and here we weren't adding any dyes. We were using a laser to induce changes in the endothelial cells, which were then resulting in platelet, in clot adhesion. And what in this particular model, fibrin deposition and more dramatically platelet accumulation were significantly reduced compared to the wild-type mice. And we think this is somewhat consistent with the previous ex vivo flow model, suggesting that fibrin deposition initially on the surface is important substrate for subsequent platelet growth and eventual development of an occlusive thrombus. Now, we've looked at some models that may be thrombotic, but may in fact be more complex and have other components to them. And this was work that was done in collaboration with Thomas Rene again. And this is a artery of middle cerebral artery occlusion, which is often referred to as a stroke model, but in reality what it is it's an ischemia reperfusion injury model, where a thread is actually passed up the carotid artery and into the middle cerebral artery and left there for a period of time, and then the thread is removed. And the end result is infarction of tissue, as seen here in this section strained with TTC. What happens is this compound is converted to a reddish-brown color in tissue that has adequate NADPH. Of course, this tissue here does not have that, and that's why it appears pale. And you can see evidence of tissue necrosis. And also, there is some formation of clot within blood vessels. Now, this assay has been used by a lot of groups, and anti-inflammatory agents will actually have beneficial effects on this in addition to anticoagulant agents. So it could well be that the reperfusion injury here isn't entirely a clotting process. And there was it was alluded to that using some of the compounds that are being generated to look for anti-inflammatory effects in some of the mouse models may be worthwhile. This may in fact be one of them. So in mice that are lacking factor 12 or factor 11, the amount of tissue damage is considerably less. And actually, from a phenotypic standpoint, the mice behave differently. The mice who suffer these kind of injuries are hemiparetic, and actually most of them die within 24 hours. These animals here actually have relatively little evidence of a neurologic deficit, and there have been actually neurobehavioral studies done on the animals, and they really don't look like they've incurred much damage. Here you can see these MRI scans at day 7. The animal that's had this stroke has had a reperfusion injury bleed, and despite the fact that factor 11 and factor 12 deficient mice have very long PTT clotting assays, there was no evidence of any hemorrhage in these particular systems, animals as well. So what we've been looking at so far is the effect of complete deficiency of the proteins of interest. And so the data suggests they may be reasonable targets for therapeutic inhibition. What level of inhibition do you need in order to get some sort of a beneficial effect? And we've been collaborating with workers at ISIS Pharmaceuticals using antisense oligonucleotides to knock down expression of various clotting factors, in our case factor 11, factor 12, and prekallikrein. I'm going to show you some of the data for factor 11. And these oligos are essentially naked nucleotides that have a sequence that's going to correspond to the message you want to knock out, along with these wing structures that are going to stabilize the structure and enhance its uptake. And the nucleotides tend to be taken up preferentially in the liver and the kidney, not to a large extent in other tissues. So since most of the clotting factors are made in the liver, this is perfect for us. And so this is actually borrowed from Alexei Ravenko, who works at ISIS. And essentially what it shows is that specific antisense oligonucleotides can be used to knock out the messenger RNA expression of whatever clotting factor it is you're interested in. And this was done with factor 11 in mice, and what you can see is that as you knock down the message, there's a corresponding reduction in the amount of factor 11 antigen and activity in the plasma. And if you look in a thrombosis model, and I think this particular model might be a venous thrombosis model where we're actually trying to assess the volume by measuring platelet factor 4 RNA. What you can see is when you get down to a level of about 40 to 50% of the normal factor 11, you start to see an antithrombotic phenotype. And this actually has been reproduced also in cynomolgus monkeys. So you don't have to have a complete inhibition or complete loss of factor 11 in order to get a beneficial effect. Phase 1 trials in humans with ASOs that knock down factor 11 have been completed, and normal volunteers were made severely factor 11 deficient without any apparent consequence. And a phase 2 study is now being done to see if this type of strategy will actually have an antithrombotic effect in patients who are undergoing knee and hip replacement surgery. That's actually, they've already started recruiting patients for that, so it'll be interesting to see. So, I just want to go over some of the data we've generated relatively recently with some of the new compounds that Dr. Desai has sent us. And what we have done so far is we've used the ferric chloride injury model to assess the antithrombotic capacities of these proteins. And when you start using these drugs, which were developed using human reagents and human systems, human plasma, that type of thing, and move into mice, you have to ask yourself a few questions. You want to know, is the mechanism you're going to be studying similar in the mouse and the human system? And as far as we know, factor 12, factor 11, factor 9, which is sort of the intrinsic unit that we're studying here, you can swap proteins from mice and humans back and forth, and they seem to behave similarly. You want to know, does the therapeutic agent interact with the murine target similarly to the human target? We actually were able to assess that for a few of the targets, and I'll just describe what we got. And then this isn't, the issue of pharmacokinetics comes into into play. We really have no idea how these reagents are actually behaving in the mice, what their half-lives are, how fast they're being cleared. Regardless of what you're using, things tend to be cleared much faster from mice than they are from humans. So the data, just keep that in mind, is the data I'm going to show you, where we're looking at dose escalation studies, really doesn't tell us what the actual plasma concentrations of the reagents are. So when you start thinking, well, that looks better than that, take these issues into consideration. So we have a number of compounds here, and the ones I'd like you to just pay attention to primarily are SBO4L and SPGG and SMI. These are reagents that I believe were designed, correct me if I'm wrong, Umesh, to target the heparin binding sites on the catalytic domains of these relevant proteases. And then these are heparin mimetics that are going to be binding to the pentasaccharide binding site on antithrombin. And the idea here is to produce, as you saw, an allosteric effect on the proteases. RAM50, which is a 10A inhibitor, or something else. But using the ferric chloride model at 3.5% ferric chloride inhibition, what we see is that with these agents is as we escalate, we can get to a situation where we essentially prevent occlusion for all of these reagents, okay? Interestingly, the lowest concentration of, lowest amount of drug we tested for the factor 11A inhibitors worked the first time. Now, does that mean the 11A inhibitors are more antithrombotic than the thrombin inhibitor? No, remember what I told you. We really don't know. It could be that the half-life of this protein is very long, and this one's being rapidly cleared, and so we have to work all of that out first. But we also might be looking, I find this very, very encouraging, obviously, because this is a demonstration that this drug, which had such promising effects, as you saw Ramy demonstrating earlier, actually can have an antithrombotic effect in vivo. Mice, the ferric chloride model in mice might be very, very similar to a PTT assay in human plasma, where it's driven and dominated by factor 12 mediated activation of factor 11. And if you work with human plasma long enough, you realize that anything that hits the top of the cascade hard enough is going to have a much more dramatic effect on the output, be it time to clot formation or whatever, than something that hits the bottom of the cascade. So some of the oral thrombin inhibitors and factor 10A inhibitors that are currently in practice in use have relatively modest effects on the PTTs, but they still have a good antithrombotic effect. So the mouse may be more like a PTT assay than a human might be, and that may be why we're seeing this type of phenomena here. Now, I think we have a lot of work to do. I'd like to try different thrombosis models, and maybe the laser injury model would be a great place to look at these drugs. We also noticed that if we crank the ferric chloride concentration up higher to 5%, and remember, 5% ferric chloride injury was a concentration where conventional dose heparin failed most of the time to protect the mice from thrombosis. These agents were not protective. But I think from this starting point, we can go and push the doses of these and see if we can even overcome the inhibition, the thrombotic stimulus by 5% ferric chloride, which in our hands is a significant vascular injury. So we're very encouraged by this. Now, in the future, it may be the case that you're going to run into a compound that looks very promising in preliminary work that doesn't cross-react with the mouse protein. We actually have murine factor 11A, and we're able to show that the drugs in question actually inhibited murine factor 11A. But it's conceivable you may end up with a drug that doesn't. One of the nice things about 11 and 12 deficient mice is they're very healthy. They breed normally. You can generate them in any number you want, and then you can go and infuse human factor 11 or human factor 12 in them and make a kind of a chimeric hybrid system in which you can test your human-specific protein or human-specific drug. And actually, an occasion to do that occurred recently. We developed a factor 12, an antibody against factor 12, primarily for the purpose of testing it in baboons as an antithrombotic. But we wanted to see if it actually had antithrombotic properties in mice because it's so much easier to do. This antibody will not cross-react with murine factor 12. It was raised in mice, and that's not surprising. So what we did is took the 12-deficient mice and gave them human factor 12, and we're able to demonstrate that one of these antibodies, 15H8, can completely prevent occlusion. It doesn't do anything to a wild-type mouse because it fails to cross-react. So in the future, if you come up with agents that may not cross-react with their human targets, with the murine target, we can still test them in the mice and get some data. Okay. How are we doing time-wise?
4:24, so we have about 20 minutes.
20 minutes. Okay, so I'm not going to take 20 minutes. So one other thing we've been able to do with the knockout mice is to actually start to study structure-function relationships in the factor 11 molecule, which may reveal new pathways or new sites that might be the targets for future therapeutic agents. So without going into a ton of biochemistry on human factor 11, this is a schematic diagram showing you that the factor 11 subunit is comprised of 4 so-called apple domains, and they actually fold together into a disc, and a trypsin-like catalytic domain. And what makes factor 11 unusual among coagulation proteases is it's actually a dimer of 2 of those units. So this is what one of the units looks like. Here's the apple domain disc. The catalytic domain sits on it like a cup in a saucer, so you get this kind of compacted structure. And in the full molecule, you have 2 of these structures at about 70-degree angles to each other, connected by a hydrophobic interface in a disulfide bond. And really, it's not entirely clear why the protein is a dimer. That it is likely important is suggested by the fact that it's so highly conserved across all species that have factor 11, which is most mammalian species. But when we go and separate the 2 halves of this through various techniques, disrupting the hydrophobic interface, you end up with a molecule that seems to do pretty much all of the things that factor 11 and factor 11A can do in our traditional in vitro systems, okay? Like clotting assays. So what we've done is we've gone and expressed monomeric factor 11 in mice through a technique called hydrodynamic tail vein injection. And I will admit that this is sounds like a relatively crude technique, and that it worked as well as it did for us is fortuitous. But essentially what we do is we go and take a expression construct like you might use in vitro cell culture with the factor 11 cDNA controlled by a promoter. It can be the cytomegalovirus promoter, it can be an albumin promoter, something like that. And we dilute it in a large volume of phosphate buffered saline. In fact, a volume that is greater than the mouse's blood volume, about 2 mLs. We then inject that into the mouse's tail vein over about 10 to 20 seconds, very rapidly. I thought we were going to kill most of the mice when we did this. They actually tolerate it very well. Their weight obviously goes up a couple of grams, but after about 6 hours, they've mobilized that fluid and got rid of it. Apparently what happens when you do this is there's a pause. Everybody remembers the Frank-Starling curve for cardiac function. There's a pause in the cardiac cycle, which puts back pressure through the venous system and results in the liver being engorged. And so it's primarily the liver that the DNA construct in the fluid is going to get into, and which is great for us because most of the proteins we're interested in come from the liver. And what happens when we use a CMV promoter is that within 12 to 24 hours, we get a level of factor 11 in plasma, of human factor 11 in the mouse plasma, that's comparable to the concentration of factor 11 in human plasma, somewhere around 30 nanomolar. Now, it drops off quickly. Why? This isn't related to antibody generation against the human protein. This is actually shutting down of the expression level. The CMV promoters apparently don't have long lifespans. They are shut down through a mechanism that I can't quite recall, but that's typical. If you use an albumin promoter, you get a more gradual upswing in expression levels, and it doesn't get quite as high as this. So anyhow, we can express factor 11, in fact, human factor 11 and factor 11 deficient mice, and try to get an idea of what's going on. And so we did that with a construct for a monomeric and dimeric factor 11. And what we have, this is a factor 11 control on a Western blot. This is factor 11 deficient plasma. This is the 11 deficient plasma from 11 deficient mouse expressing wild-type human factor 11, and this is the mouse expressing monomeric 11. And the monomeric 11 lacks that disulfide bond and a few other residues, and if you actually go and gel filter the two different proteins, you can clearly see that they are different in size. It's truly tracking as a monomer. So despite the fact that this protein activates factor IX normally, despite the fact that if you put this into 11-deficient human plasma and do a PTT assay, it looks like it corrects the abnormality perfectly, the monomeric proteins we've tried reconstitute the mouse thrombosis, the ferric chloride thrombosis model very, very poorly. And so this is the first evidence I'm aware of that dimeric structure actually has a functional consequence. We have a working hypothesis as to why this might be. We think that the dimeric structure is actually, if you look at vitamin K dependent clotting factors, they have mechanisms for sticking to phospholipid surfaces and activated platelets. Factor 11 lacks that, and it may be actually using one subunit to interact with a surface and the other subunit to actually carry out the catalytic function. And we're trying to work that out. Okay, so to finish up, I just want to raise one warning about all the work in mice, and obviously mice and humans are different. There's epidemiologic data to suggest that what I've just told you about the 11-12 system in mice may not apply completely to humans. So from the standpoint of factor 11 and drugs that are targeting factor 11, the news is good. There's an abundance of data indicating that 11 contributes to thrombotic disease in humans. So if you are in the upper end of the normal population for factor 11 level, you have an increased risk of myocardial infarction compared to everybody else. There's an independent risk factor, an increased risk of stroke, and an increased risk of deep venous thrombosis. If you are congenitally deficient in factor 11, you have a decreased risk of stroke, and you have a decreased risk of venous thrombosis. That all looks good. The issue with factor 12 is problematic. The original factor 12 deficient patient, a man named John Hageman, actually died from a pulmonary embolism. And from that point on, you see factor 12 deficiency appearing periodically on lists of things that actually promote blood coagulation, promote thrombosis, instead of protecting against it. That's probably a bit of an overstatement, but recent data actually raises the specter that 12 deficiency may actually predispose to some extent to thrombotic disease. These two large studies, this is a study that was performed in Holland. This is the myocardial infarction study done in Leiden, Holland, and a large study done in Austria showed that while increasing factor 11 levels are associated with increased risk of thrombosis, decreasing factor 12 levels are associated with an increased risk of myocardial infarction and cardiac death. Now, the peculiar thing here in this particular study was this study was large enough to actually have a cohort of people that had very, very low factor 12 levels. So most of this work was done within the broad range of normal factor 12 levels. So it's about a threefold difference in concentration. But they had some severely deficient people here, and the severely deficient people looked more like the mean for the entire population. So it's a very confusing story. But we haven't been able to clearly determine whether or not 12 is simply not 12 levels aren't an indicator of risk factor, or if they are actually low levels of 12 actually confer risk. So given that, the issue of whether or not what we saw in the mice, how that translates to primates and humans arose. So we've been interested in looking at the role of factor 11 and factor 12 in primates for some time. But even before we were, Andres Gruber and his colleagues at the Oregon Health and Science University were interested in this. So we've been working with Andres now for about 5 years. And he has a model in olive baboons, Papua nubis, where an arteriovenous shunt is created in the femoral blood vessels, between the femoral artery and the femoral vein. So this is like a shunt that you might put in a patient who needs hemodialysis, only this is exteriorized, so it's outside the animal's body. And small dacron grafts that are coated with collagen or various thrombogenic substances can be put into the animal, and the clot actually occurs within the dacron graft. So this is what the device looks like. This is the blood was going to be flowing this through here. This is a collagen-coated chamber. Most of the clotting is going to be initiated here, and then they can determine deposition of platelets, which are radiolabeled with indium, and deposition of fibrin, which is radiolabeled with radioactive iodine, within the chamber using a gamma camera, and they can take samples from downstream and look at things like thrombin, antithrombin complex, and other markers of coagulation. And the animals can tolerate these shunts for, I think, a week or so. If you leave them in too long, they're going to go into heart failure, so they try to avoid doing that. Okay, so the antibody O1A6 targets human factor 11 and cross-reacts with baboon factor 11. It actually sits on the exosite on factor 11A that factor 9 binds to. So it's a very potent anticoagulant in vitro. And when this antibody was administered to baboons, essentially you get this plummeting in factor 11 activity that lasts for over a week. The interesting thing is the factor 11 is actually not cleared from the plasma by this antibody. If anything, the antigen level actually rises, as if the normal clearance of the protein is interfered with. But you can't measure any of its activity. And what happens in the thrombosis model in the presence of the antibody is fairly impressive. At high shear, so this would be similar to what you might see in an artery, and they can adjust the flow through the graft by a clamp kind of method. In the presence of the antibody, you essentially have a blunted platelet deposition. What is actually happening is platelets are binding to the surface of the thrombogenic shunt graft, but three-dimensional growth of the platelets of the platelet plug is diminished, is blocked. And you don't get occlusion of the graft as you do in the control animals. And in fact, you can see shedding with the gamma camera of pieces of clot as they break loose. And you also have a reduction in fibrin formation as well. At lower concentrations of shear, you see the same effect of the antibody, which is marked here. And you get a marked reduction in thrombin antithrombin complex and a marked reduction, these are the bars in red we're looking at, in beta thromboglobulin compared to animals that are not treated. And usually the way this is done is an animal serves as its own control, so you do a few tests in the animal, give them the antibody, and then do a few more tests. We suddenly, and I don't have this in graph format yet, have gotten data in the same model with two other antibodies. One of them is an antibody to factor 11 that blocks its activation by factor 12, but appears to do little else. And the other is the antibody 15H8 to factor 12. And what we see there is that there is an antithrombotic effect, but it is not nearly as dramatic. It does not seem to work particularly well at the high shear conditions you might see in an artery, but has more of an effect on the venous flow rate type of model. So there could be a number of reasons for that. It could be that the primate is indeed different from the mouse, that the system is not 12 dominated here, and factor 11 is being activated perhaps through feedback activation or something else. It is very difficult to completely block factor 12, however. The plasma concentration is high. It's approaching 1/2 to 1 micromolar, so it's difficult to get enough antibody in there. And you only need a small amount of factor 12A to actually induce the factor 11 activation. So we're not sure at this point if the difference between the 12 antibody and the 11 antibody is truly reflecting a difference in physiology, but just something to keep in mind. So the people pharmaceutical companies raise the issue: which should be a better target for inhibition, factor 12A or factor 11A? Factor 11A clearly has a lot of the data going for it. Factor 12A would be great because you don't seem to bleed excessively if you're missing 12A. In fact, we're not exactly sure what 12A is necessary for because people missing it seem to be relatively healthy. But I think some of the data of the type that I just described for you has given pause to using 12A as a target, and 11A is considered maybe more of a pure anti-thrombotic target. So just to finish up, mice have provided us with a variety of options for elucidating key pathways involved in thrombus formation and identifying potential targets for therapeutic manipulation. But when we use these animals, we just need to keep in mind, as has been brought up before here, that mice or any animals are not humans, that the systems we use to test them are indeed models that may be demonstrating the exception rather than the rule. And so a good approach to investigating new agents is to try them in a variety of models, and probably in different species. Regardless of how many models we use, the issue of taking that preclinical data and trying to make a determination on what's going to work when we take it to clinical, these big, expensive clinical trials, is something that keeps keeps executives at pharmaceutical companies up at night. While we can make these animals have a thrombotic event, what we're doing in essence is creating a thrombus in a blood vessel that never would have done it on its own because they were healthy to begin with. And how you go about modeling the 70-year-old circulatory system of somebody with diabetes is a much more difficult problem. So as much success as we may have with the animal models, there's still not necessarily a translation, and that's obviously work for the future. So some credit where credit is due. Most of the animal studies done in my laboratory are done by Dr. Qifeng Cheng and Chuck Bain. My mentor, George Brose, was involved in some of the earlier studies with the factor XI deficient mice. Thomas Rene at the Karolinska Institute has been a long-time collaborator. Dr. Desai, again, thanks for inviting me to speak here. And then my colleagues at ISIS Pharmaceuticals, who we've been working with on the oligo knockdowns. And if you have any questions, I'd be happy to answer it. Thanks so much for your attention.
How is 11A tethered to the membrane?
The question is it tethered to the membrane? This gets into an area of controversy. It appears that factor XI can bind to platelets, and probably the platelets need to be activated. Some data suggest the glycoprotein 1B receptor is the binding site, although there are many more GP1B molecules on a platelet than there are factor XI binding sites. So that's not exactly certain. There's some data suggesting the ApoER2 prime receptor for the apolipoprotein protein on the platelets may also be a binding site for factor XI. But whether or not that binding to a membrane is actually necessary, you assume it is because it is for every other coagulation protein. That really hasn't been demonstrated. Factor XI also binds avidly to the polyphosphates released from platelets. So what it is and that's probably actually critical for normal factor XI activation. So, but what it is that factor XI actually is binding to in these reactions really hasn't been established. You would think in some of these flow systems, it would have to bind to something just to stick around and do its thing, but that really hasn't been established. Yeah?
I really enjoyed your talk. Could you tell me, is there any interaction with protein disulfide isomerase, with the cryptic tissue factor interaction, whether it's something analogous?
For factor XI?
Yeah, because it's
the disulfide bond. And I am not aware that anybody is even, it's an interesting thought. I'm not aware that anybody's even looked at that. The disulfide bond doesn't seem to be actually critical for dimer formation. There is at least one species, the rabbit, that doesn't have it, yet the protein's a dimer. And there actually is a human being or two that lacks it also, and their protein is a dimer. It's just a spontaneous mutation. So I'm not sure that it is actually that important. So if manipulating it even through something like disulfide isomerase would change the function, it seems to be dispensable.
Okay, thanks a lot.
My pleasure.